Hello and welcome to Cardiac Imaging Agora. This session is very special for me. I have a very good friend and wonderful mentor, Dr. Harry Lever. Dr. Lever knows about hypertrophic cardiomyopathy more than probably anybody in the universe. And he's on a quest for discovery every time he sees a patient with hypertrophic cardiomyopathy. He's never satisfied with what he knows. And not only he learns about it himself, he teaches us all about it. Dr. Lever, the floor is yours. Educate us.
Thank you very much, Whale. Thanks for this opportunity to talk about hypertrophic cardiomyopathy that's really become part of my life. First, I'm going to show you two cases to show how there's a broad spectrum of the disease, and then we'll get more into details. First is a 21-year-old college student who was noted to have a heart murmur. He subsequently developed palpitations and an echocardiogram was done. Genetic studies revealed two variants of the myosin-binding protein C3 gene. This is a parasternal long axis view showing rather significant left ventricular hypertrophy here involving the septum. There is some resting systolic anterior motion of the mitral valve with a normal aortic valve, reasonably normal sized left atrium. Here is a M-mode picture showing some systolic anterior motion of the mitral valve here. Septum is roughly about 18 to 19 millimeters. And here another view further down in the ventricle. And here we have a short axis view showing rather significant anterior wall hypertrophy, lateral wall hypertrophy, but the septum is not well seen. Next is an apical four-chamber view with showing a rather prominent papillary muscle and some systolic anterior motion. The right ventricle is of normal size, left atrium is not well seen. Here we see, again, parasternal long axis view, very mild mitral regurgitation. Here we have apical four-chamber view, again with severe hypertrophy and some, go back, mitral regurgitation. Here, posterolateral mitral regurgitation. Patient then did a valsalva maneuver and the, and the gradient was about 64 millimeters of mercury. Here we see after giving amyl nitrite, the systolic anterior motion markedly increased. And here the mitral regurgitation also increased. The gradient with amyl went to 90 millimeters of mercury. So this is a patient with rather severe hypertrophy and provocable outflow tract obstruction. The next is a 50-year-old gentleman who had a sudden increase in heart rate with dizziness. An echocardiogram was inconclusive. Shortly thereafter, while watching a debate, he developed sudden racing of the heart and lost consciousness. Holter monitor revealed an episode of ventricular tachycardia at a rate of 207 beats per minute. Stress echocardiogram showed an increase in gradient with a drop in blood pressure, and ICD was placed. Here we see that the patient has very mild septal hypertrophy. There is some systolic anterior motion, but look very carefully here. There seems to be some attachment here into the body of the leaflet. Not at the tip, but at the body. Next, the patient was given amyl nitrite and he developed severe systolic anterior motion. But again, notice the septal hypertrophy is not significant. Next, with amyl nitrite, the gradient was 98 millimeters of mercury. Here, a transesophageal echocardiogram was done, and you see that the papillary muscle is nearly directly attached to the anterior leaflet of the mitral valve. And interestingly, there is posterior leaflet prolapse. So here we have direct attachment of the anterior leaflet of the papillary muscle to the anterior leaflet and posterior leaflet prolapse. The next view, we see that the patient actually had bileaflet prolapse. Patient underwent a stress echocardiogram and had severe systolic anterior motion, but again, notice there's no septal hypertrophy. The gradient went to 221 millimeters of mercury. This patient was subsequently taken to the operating room, and it's interesting. He did not have a septal myectomy. The papillary muscle was detached from the anterior leaflet, and the prolapse was repaired, and he got better. So here he had no hypertrophy, but yet severe provocable outflow tract obstruction. Now, hypertrophic cardiomyopathy was once thought to be just a heart muscle disease in which there was septal hypertrophy. However, hypertrophic cardiomyopathy is not just a thick septum. There is the syndrome of outflow tract obstruction, OCM, or obstructive cardiomyopathy without hypertrophy. Now, the echocardiogram is very helpful in assessing the heart for anatomy and physiology. What do we look for when we're looking at a patient that we suspect has some form of hypertrophic cardiomyopathy? We look at the ventricular muscle, the papillary muscles, the chordae tendineae, and the mitral valve. There's a complex interaction of the mitral valve, the papillary muscles, the chordae tendineae, and the ventricular septum that causes obstruction and mitral regurgitation. In terms of looking at the ventricular muscle, we have to decide, is hypertrophy present or absent? What is the location of the hypertrophy? Is it in the proximal septum, the whole septum, or it may be concentric hypertrophy, or you may just have lateral hypertrophy, and there is a group of patients who have only apical hypertrophy. We look at the papillary muscles, we need to know the number of papillary muscles and their location. Are they medial, lateral, or apical? How many heads do they have? What are the size of the papillary muscles? And how strong are they? That is, how well does it anchor the mitral valve? Now, the papillary muscles may be directly attached to the leaflets. There may be anterior or apical displacement, or they may actually be attached directly to the septum. Now, if we look at the development of the mitral valve, it's interesting. First, the leaflets form, then papillary muscles, and last is the chordae tendineae. But what happens if a chordae do not form? This is how you get direct attachment of a papillary muscle to the leaflet of the mitral valve. Now, the next few slides show varying papillary muscles configurations. You can have a single belly papillary muscle, as seen here, here, and here. You can have two bellies, seen here and here. Here's another one with a somewhat different two-tiered approach, or interlinked, as seen here. So wide variety of how these papillary muscles look. Here's another one where there are three bellies, 1, 2, and 3, and again in this view, two-tiered and then a single one. So multiple three-bellied papillary muscles. Here's one where there is near attachment to the annulus. And here, anterolateral chordal fan totally destroyed. Here looks like, tends to make it look actually totally attached to the leaflet. Here is an echocardiogram where where the papillary muscle is directly attached to the mitral leaflet. Now, again, it's very important to know how these things are attached. Normally it's to the leading edge, but again, it can be to the body of the leaflet. We need to know the length of the cords and are they flail. Sometimes we see flail leaflets in these patients. The mitral leaflets can be normal. You can have a large anterior leaflet or a large posterior leaflet, or both leaflets can be enlarged. Now, we need to look at the physiology with the echocardiogram. And we need to know whether there's resting obstruction, latent obstruction, or no obstruction. How common is obstruction? Well, this is a study done by Dr. Martin Marin. He looked at 221 patients. About 29.4% had no obstruction, 41.2% had resting obstruction, and 29.4% had provocable obstruction greater than 30 millimeters of mercury. Overall, 70.6% of patients had resting or provocable obstruction. Now, the mitral valve is like a sail in the wind. And as that wind goes, so goes the mitral leaflets, depending on their shapes. Now, conditions needed for systolic anterior motion of the leaflet is anterior position of the coaptation point, positive angle of attack between the outflow and the protruding leaflet seen here, or chordal slack. Now, this is another diagram showing the mechanism of SAM. This is before the myectomy with chordal slack, and after the myectomy, the leaflet tends to fall backwards. Sometimes we have to remove the slack, but many times we don't have to. But if it's too long, then we have to remove the slack or shorten the anterior leaflet. Now, this is an interesting diagram showing what happens when the papillary muscle is apically displaced. It tends to move the anterior leaflet closer to the septum, and you can get outflow tract obstruction. We need to know, is there mitral regurgitation and its severity? Now, SAM-related mitral regurgitation, the degree of MR is related to the leaflet length. We need to look at jet direction. It's important in differentiating the mechanism of the SAM. Normally, for outflow tract-related mitral regurgitation, it's a posterolateral jet. If there's a flail leaflet, there can be varying directions of the mitral regurgitant jet. With a calcified mitral annulus, there's a lack of contraction of the annulus, and the jet tends to be central. So for SAM-related, it's posterolateral. If it's flail, you can have varying degrees of varying jet direction. And again, for calcified mitral annulus, it tends to be central. Now I'm going to show you a group of diagrams showing you the variety of anatomy that we can see. Here's normal septum, normal papillary muscles, normal mitral leaflets. Next is a classic severe proximal septal hypertrophy with a normal mitral valve, normal papillary muscle. Next is a severe hypertrophy like seen before, but this patient had a long anterior leaflet, normal papillary muscles. Here you can have severe hypertrophy with apically displaced papillary muscles and a normal mitral valve. Here we have normal septum, normal leaflets, apically displaced papillary muscles. Here we have normal septum, only an elongated anterior leaflet, but normal papillary muscle. Here we have severe hypertrophy, elongated anterior leaflet, apically displaced papillary muscles. Here is a normal septum, elongated anterior leaflet, apically displaced papillary muscle. Here we have bifurcated papillary muscles, normal mitral valve, normal leaflet. Normal septum. Here we have severe hypertrophy with bifurcated papillary muscles and normal leaflets. And again, here we have severe hypertrophy, elongated anterior leaflet, and bifurcated papillary muscles. So many combinations of anatomy. And here is one way where this situation can be repaired, where the papillary muscles are sewn together. This patient would have had no hypertrophy. So frequently we require multimodality imaging. The transthoracic echocardiogram gives an overall view of the heart, but sometimes the pictures are not ideal, and we need an MRI scan to look at the muscle anatomy and whether there is scar. Scar is important to look for because with increased scar, there's an increased incidence of arrhythmia. Transesophageal echo is helpful when the images by echo are not ideal, and it gives a better definition of the leaflets and their attachments. In summary, hypertrophic cardiomyopathy has a broad spectrum. This is a problem of geometry. The hypertrophy can be in a variety of locations and severity. The leaflets can have varying sizes, and there can be varying degrees of MR. Papillary muscles can have different locations and orientation. You can have multiple heads, direct attachment to the anterior leaflet, and obstruction can be resting, latent, or none. Hypertrophic cardiomyopathy is a complex disease that requires a clear understanding of all the anatomic variables before the symptomatic patient can be successfully intervened on. Now I'm going to show you a few more cases. This is one that had papillary muscle abnormalities. And this is one, this was an MRI scan showing apically displaced papillary muscles. Seen here, the gradient and hypertrophy. Seen here, the gradient was 101 millimeters of mercury. Next is an 18-year-old gentleman with a recent onset of extreme fatigue after eating a large meal. In addition, he had palpitation and had dizziness. He was told he was anxious. This is an electrocardiogram, which was normal. Here we see patient has a large papillary muscle, almost apically displaced, but no septal hypertrophy and no resting obstruction. Next, we did a stress echocardiogram, and he had developed severe systolic anterior motion. And the gradient was 118 millimeters of mercury. Next, we looked down further into the apex of the ventricle with transesophageal echo, and you'll notice the papillary muscle was quite large. Here, the patient was given isoproterenol, and he developed severe systolic anterior motion. And severe mitral regurgitation. Next is the MRI scan, and you'll notice again, no hypertrophy, but this large papillary muscle here with a smaller one here, basically a bifid papillary muscle. You can see here. Next, we gave a gadolinium. And interestingly, the patient had no scar, and thus his risk for VT was very low. The question is, does he have hypertrophic cardiomyopathy? Turns out he was myosin-binding protein C3 without hypertrophy, but he had that papillary muscle, which contributed to the outflow tract obstruction. Here, post-operatively, there's no systolic anterior motion. And here, again, no evidence for systolic anterior motion. Next is a 45-year-old woman with a family history of sudden death. She had complaints of fatigue and shortness of breath. She was gene positive for myosin-binding protein C3, and she already had an AICD. Here we see bifid papillary muscle, rather significant hypertrophy in this apical two-chamber view. And with the valsalva maneuver, she had an 83 millimeter gradient. Next, the septum was measured at 27 millimeters of mercury. And again, here showing severe systolic anterior motion. And turns out her gene was novel. Next is a patient with mitral leaflet abnormalities. 51-year-old gentleman with stress-related chest pain, shortness of breath, and palpitations. His electrocardiogram was normal. Turns out he had some evidence for posterior leaflet prolapse and mild systolic anterior motion. Here he had some anteriorly directed mitral regurgitation, probably 2+, at rest. He was given amyl nitrite, developed severe systolic anterior motion, and severe posterolateral mitral regurgitation. Next was a 21-year-old college student with exertional shortness of breath and a family history of sudden death. He already had an ICD when I saw him, And interestingly, with amyl nitrite, this patient had posterior leaflet SAM with minimal proximal septal hypertrophy. There was some more hypertrophy closer towards the apex. But look at this marked systolic posterior leaflet SAM. And here again, we see posterior leaflet SAM and lateral wall hypertrophy. Anteriorly, there was not much hypertrophy. So this is a disease of wide spectrum. Thank you very much for your time.
Thank you, Dr. Lever. This is a fantastic overview of the disease. And of course, we're going to get you back to talk about some of the management strategies and how we use anywhere from medications to ICDs to surgery and to even alcohol septal ablation. I have two questions for you. One is a career question. You got interested in this and built a beautiful, wonderful career, helped a lot of people over this. Tell us just briefly, how did you get involved in this as a career?
Well, it was interesting when I trained in my cardiology at the University of Rochester, and they were early into hypertrophic cardiomyopathy when all we had was M mode. And I trained with one of the original investigators, Pravin Shah, and I learned a lot from that. And then I joined the University of Pittsburgh. I was there for a short time and continued my interest. But then when I joined the Cleveland Clinic years ago, because we see so many different kinds of patients, I was able to find lots of hypertrophic cardiomyopathy patients. And so I started seeing more. And it was interesting, in 1996, I met a woman at the American Heart Association meeting in New Orleans. Interestingly, I was on the last plane out of Cleveland that Saturday afternoon in November because of a snowstorm. And I met her there. She had actually contacted me before. Turns out she had just formed a support group for patients with hypertrophic cardiomyopathy. And she became the single biggest referrer of patients to us. And she continues to refer us patients. And as a result, that's how I got to see so many patients and learned a lot about this disease. The other thing was our surgeons had learned to repair the mitral valve in mitral valve prolapse, so that when we started seeing these mitral valve abnormalities in hypertrophic cardiomyopathy, we recognized that they could be repaired similar to mitral regurgitant patients who had only prolapse. So that was a help as well.
Harry, what I admire about what you've done is not only you started this very early with limited technology to image it and to do it, is how you expanded and accepted. You didn't have a fixed mindset towards it. So as echo evolved, you evolved with that. As transphageal echo, you evolved with that. You accepted MRI as part of your practice. We'll talk another time about the metabolic stress echoes and all these things you've done. This is really inspiring for all of us to just not have a fixed mindset and keep learning about the disease. The other question I have for you is just briefly before we have to close is, and I learned this from you, is the issue of provoking the gradient. So many times we've had patients sent to us and been told they're not obstructive. And you taught us all that it's not enough. You have to mimic some physiological changes to do that. You used to do it by stethoscope. So tell us how often do you have to do that, and when are times when you don't have to do it?
Well, if we clearly see resting systolic anterior motion and a resting gradient, there's no need to provoke it. But if you're suspicious, there's septal hypertrophy, the patient may be having dizzy spells or lightheadedness, we use a lot of amyl nitrite. And the interesting thing about amyl nitrite is I learned about that when I was a fellow back at the University of Rochester. That's where they were using amyl nitrite, and I brought that to the clinic. And it's a short-acting form of nitroglycerin that you inhale, and rarely does a patient get significant symptoms. They might get a little dizzy, although one time I remember we gave it to one patient who the mitral valve stuck open for maybe 5 minutes, severe mitral regurgitation, and she got really dizzy. But we don't see that happen very often. And the good thing about the use of this medication is it's very short acting, and most people have no trouble at all. We also use the valsalva maneuver, and that can be very helpful as well. And then of course, when we're looking, we want to see how the patient is doing. We frequently do a stress echocardiogram. I've had many patients who come to see me and tell me that they're feeling terrible, and we put them on a treadmill and they do well. And other patients say they feel well and they can't do anything on the treadmill, and we see severe obstruction. So it's very helpful that we have to look for, we have to provoke the patient. We can't just go by the resting echocardiogram.
Thank you so much, Dr. Lever, and thank you for your time. Really, it's an imposition on you. We appreciate it, and we'll get back to you soon to tell us more about the treatment strategies for hypertrophic cardiomyopathy. Thank you.
Thank you very much.